Hi, my name is Michelle Hemley, student ID 11543442, and this is my presentation for Pathophysiology of Chronic Conditions, EHR 403, on dyslipidemias. Throughout this presentation, I will be referring to the case study of Peter in Module 2.1, a 52-year-old bank manager who has abnormal blood lipid levels. First of all, what is dyslipidemias? Dyslipidemia is a collective noun referring to excess or deficient blood lipid levels. Lipids are classified as triglycerides, phospholipids and cholesterol. In Australia, elevated blood cholesterol is a major public health concern, as elevated cholesterol accelerates the development of atherosclerosis, which leads to a range of conditions such as coronary artery disease, peripheral vascular disease, heart failure, stroke, and the resulting complications of these conditions. If we look at some recent statistical data of cholesterol levels in Australia, the Australian Diabetes, Obesity and Lifestyle Study of 1999-2000 indicated 6 million Australians over 25 years had elevated blood cholesterol above 5.5 millimoles per litre. This study analysed blood cholesterol measurements. The Australian Bureau of Statistics National Health Survey 2004-05 estimated 1.3 million Australians over 25 had elevated blood cholesterol. The difference was this was self-reported data. The discrepancies in the findings are a result of the differences in data collection, but you can see either way it's a major problem in this country. Now we look at our case study in relation to dyslipidemias. Peter, a 52-year-old bank manager. This is his blood lipid profile in red. In green is the recommended lipid readings for a healthy individual as recommended by the Cardiac Society of New Zealand and Australia, Position Statement on Lipid Management 2005. As you can see, Peter is above the recommended readings for total cholesterol, LDL cholesterol and triglycerides, and below the recommended reading for HDL cholesterol. As mentioned in the introduction, dyslipidemias refers to a range of scenarios in relation to abnormal blood lipid readings, and Peter's subcategory of dyslipidemias is hyperlipidemia. This refers to excess cholesterol, either total cholesterol and/or LDL cholesterol, and high triglyceride levels. Several factors can contribute to increased blood lipid levels, and it is usually a combination rather than a singular factor which influences elevated lipid levels. Some factors that put an individual at risk of elevated blood lipid levels are non-modifiable. One of these factors is genetics, and a predisposition to high blood lipid levels can be inherited. For example, Snyderman, Tomiskas and Fazio 2014 found that some people have increased sensitivity to dietary cholesterol, meaning consumption of these foods will highly influence their lipid levels. Age. Risk also increases as you get older, and men over 45 years are identified as a risk factor. And gender. At any given age, men are at a higher risk than women of high blood cholesterol. Both age and gender apply to Peter as a 52-year-old male. However, we have no information on his family history. If we look more closely at how genetics can influence blood lipid levels, Pollin and Quantiaro, 2013, looked at how genetic factors influence lipid levels, responses to dietary interventions, and found a genetic difference. We also found Nazi, Hedati, Denshapur, Banzeri and Aziri found a link between low levels of HDL cholesterol and an individual's genetic predisposed amount of lecithin cholesterol acyltransferase enzyme. Lee has also made some new discoveries regarding genetic variants and specific risk factors like cholesterol. Lee made these findings after analysing 8,962 published associated studies, so it was quite a comprehensive review of the area. The good news is some risk factors for dyslipidemias are modifiable, such as a poor diet. People who have diets rich with foods high in cholesterol and saturated fat are at more risk of high blood lipid levels, as are smokers, those who participate in a lack of physical activity, those who are obese. Certain medications affect blood lipid levels, and other conditions such as diabetes and high blood pressure also affect blood lipid levels. I put these conditions in modifiable risk factors as obviously diabetes and high blood pressure are also managed due to medications and lifestyle interventions and hence are modifiable. In In regards to Peter, we have limited information about his lifestyle habits. However, we can infer from his role as a bank manager there is a lot of long hours at his work, which may mean packaged and takeaway foods for convenience, and also attendance at a lot of corporate functions. Nutritional habits may be something we can modify. So how does nutrition promote elevated blood lipid levels? High intakes of saturated fatty acids and cholesterol directly raise LDL cholesterol concentrations, and nutritional interventions have been successful in decreasing blood lipid levels. How can a clinical exercise physiologist help Peter? Hoshino, Jackson, Fukumori, Nakamura and Fukuhara, 2012, found that supervised exercise was effective in lowering LDL cholesterol and elevating HDL cholesterol. And Fletcher, 2005, reported that healthcare providers are generally not well equipped to educate and support patients in the pursuit of a lifetime physical activity program, and recommended that specialist physical activity rehabilitation professionals are engaged in a multidisciplinary approach to managing conditions such as blood lipid levels. This obviously is a great indication of the use of a clinical exercise physiologist in managing blood lipid level conditions such as Peter. At the moment, with Peter being asymptomatic of conditions relating to elevated cholesterol levels and his total cholesterol reading of 5.8 millimoles per litre, lifestyle changes are the most appropriate interventions available to him. If his total cholesterol was to rise above 6 millimoles per litre, he would also be prescribed statins, which are a lipid-lowering drug used in the therapy of LDL cholesterol. Statins work by lowering circulating levels of cholesterol by inhibiting the action of the HMG-CoA reductase enzyme at the hepatocytes, affecting plasma LDL levels. This results in lower hepatic cholesterol synthesis and a reciprocal increase in cholesterol absorption. How effective are statins in managing blood lipid levels? Statin therapy has been shown to reduce cholesterol concentrations by 20 to 30%. That finding was found by Mittinen in 2003. And a study on Australian patients with elevated blood lipid levels by Koloquin, Shirozsky, Sazonov, Amberganoka found that LDL-C levels decreased in 95% of statin therapy treatments. However, a large proportion of patients did not achieve normal HDL, cholesterol or triglyceride levels using statin therapy alone. This indicates that statin therapy should always be combined with other lifestyle interventions. So if Peter gets to the stage where he is prescribed statins, the lifestyle interventions should not be stopped. If Peter was to ineffectively manage his blood lipid levels, he is leaving himself open to developing major health complications, which can be brought on by the acceleration of atherosclerosis development. Atherosclerosis refers to the hardening and build-up of fibrofatty lesions, plaque, in the arteries that supply the brain, heart and lower limbs. Elevated blood lipid levels play an important role in the development and progression of atherosclerosis by increasing interactions between the endothelial layer and monocytes, increasing the chance of endothelial injury, and activating macrophages to ingest oxidized LDL to become foam cells in the plaque formation. Increased development of atherosclerotic plaque can lead to coronary artery disease, peripheral vascular disease, stroke, and heart failure, which all have resulting complications resulting from these conditions also. So looking at peripheral vascular disease more closely, peripheral vascular disease is when advanced atherosclerosis causes obstruction to blood flow in a vessel that is not within the coronary or aortic arch or the brain. Typically, it affects vessels in the legs. A major risk factor in the development of peripheral vascular disease is high LDL cholesterol. Clinical manifestations of peripheral vascular disease Peter would have to deal with include pain in the lower limbs, physical limitations, for example, how far he can walk and the intensity he can walk, gangrene development, and numbness in the lower limbs. Conclusions. While some personal characteristics Peter cannot change, such as his age, his genetics, which we are not informed of, and his gender, there are several lifestyle interventions such as nutritional strategies and physical activity that can significantly influence his blood lipid levels. Working with a clinical exercise physiologist will assist Peter to make sustainable activity changes in regards to the physical activity area and will assist them to become part of his lifestyle. Failing to address his blood lipid readings will have Peter commencing statin therapy sooner and accelerate his atherosclerotic development, which can lead to complications such as coronary artery disease, peripheral vascular disease, heart failure, and stroke. Here is page 1 of my references used for this presentation. Here is page 2 of my references used for this presentation. Here is page 3 of references used in this presentation. And here is page 4 of references used in this presentation. Thank you very much for your time.